Okay, so welcome. So this session we're going to go through several cases of the shoulder. So with that, we'll give you kind of a variety of cases, and you can play along with some of these with your automatic response system. So this is the first case. You get shown an axial and a coronal image, and this is a patient presenting with acute shoulder pain. So as this is crossing your PAC station, what are you thinking? And to give you a companion case with the same process in a different patient, looks slightly different, and we'll talk about something specific with this entity. Okay, so this is hydroxyapatite deposition disease. So this is a pretty common process that we see the calcification that starts to have deposition typically within the tendons. Shoulder is a very common spot for this, and typically patients don't present clinically until these calcifications start to migrate. So they can migrate back and forth within the tendon, they can be partially or completely extruded into the bursa, or they can actually go into the bone. So when it does this, these crystals are very irritating, and they produce a cascade of response of edema and inflammation. So if you look at this patient, you can see the direct calcifications as a low signal intensity focus, but look at the edema that's being incited in the bursa as well as the adjacent soft tissues. No need to give gadolinium, but if you would also see tremendous enhancement in these patients. So this is showing you a correlating case where this person went to arthroscopy. And if you look at this coronal T2 weighted image, we're showing you a focus of calcification that at first, if you're not used to looking at these images, you may misconstrue as just the supraspinatus tendon. But that's not the case, because if you look at the tendon, it's a more superior structure, and it's going to attach right onto this facet of the humerus. There's nothing else more distally that should be there. So anything that's low intensity or a signal void, you have to think about what could be causing that. So most commonly in this location, the protons are not mobile in these calcifications that are stuck. So look at the bursa. This is the subacromial subdeltoid bursa, very inflamed. And then here's a case where we're starting to see the changes deep to these calcifications. So sometimes it's hard to pick out the calcifications themselves within a normal rotator cuff tendon because they are also low signal or completely a void. But usually they add a little bit of mass effect with the calcifications. But this case I'm showing you because of the erosion that's occurring deep to the calcification. And then if you go back to our test question in the second patient, you can see the calcifications and you can confirm those on your PAC system with either a prior shoulder radiograph or look at a chest x-ray. But in this case, we had the very similar bursitis, but we also have some changes, edema within the bone because of the calcification next to it. So they can be very irritating and they can be confusing. So with hydroxyapatite, most of the time this is a self-limiting process. Patients can go on non-steroidals for pain relief, but occasionally the pain is so intense if there's a high load of calcium that has migrated, as in this case, into the bursa, that sometimes we're asked to do a lavage. So if you do this, you can do it under fluoro, under ultrasound, and what you're going to do is try to break up the bulk of the calcium, pull it out with an aspiration, and it's usually pretty chalky looking, and then inject a lot of steroids if the patient can tolerate it, as well as lidocaine and ropivacaine on the way out. And then afterwards, all patients will resorb in time, but this will be a prompter response. But just as a note, if you're asked to do this, it can really accelerate that pain threshold. So you're going to be very painful afterwards. You may have to temporarily give them possibly some opioids afterwards. Okay, moving on to the next case. So this is a 13-year-old boy who was playing football, and he came in with severe chest pain because a player's helmet speared him. So they just ran directly into his chest and had a direct impact force. So this is the film. This is a clavicle film. And just take a look at this and see what you think. And then, what study would you recommend next to really be definitive or to check for complications of this entity? Well, I would recommend a CTA, and we'll go into the findings in just a minute. But this is in bone windows, but you can see that we do have opacification of the vessels. But look at the positioning of the clavicular heads. So obviously there is a discrepancy in the positioning, and this is important because you now have to decide which one is normal, which one is not. So of course you're going to scroll through your serial imaging and figure that out, but I'll tell you this is the problem. This is posterior displacement, and you can just see with the vessels going posteriorly, knowing also the brachial plexus is going to be nearby some of these areas. You want to take a good look at the vascularity, make sure everything is patent, make sure there's no extravasation. So going back to the radiograph, this is important to really be critical because oftentimes this is the first imaging, which it should be, but it may not progress on to higher level imaging, which it should unless you, the radiologist, points it out. So it's subtle, but there's a little bit of offset in the positioning of the clavicular heads. And sometimes it's hard to make that decision. It could be poor positioning, they could be awkwardly placed. You just don't know sometimes, but CT really is going to be definitive. And if you can do some beautiful reconstructions and clearly see that you have dislocation of that. And in children, you want to really carefully look for any flecks of bone, because oftentimes these are truly a Salter Harris type of injury, and you want to be very accurate if you can in this. So this is a posterior sternoclavicular dislocation. So it's uncommon. Most of the time, these will be anterior dislocations. So when the force is placed along the mid-clavicular region, it luckily pops the medial clavicular head out anteriorly. So there's not a risk for a lot of these complications. So things we're worried about in this emergent setting is injury to the neurovascular bundle. So you've got the innominate artery and the vein. You also have the trachea and the esophagus, as well as the common carotid and the left subclavian. So really important structures. CTA is an appropriate study and definitely warranted. So you will help this patient. Okay, next patient. This is a 38-year-old man, and he felt a sudden sensation and pain while he was changing a tire. So this is an arthrogram that we do typically these days prior to MR or to CT. We really don't do many arthrograms and stop these days. But if you look at this, try to think about, is there anything abnormal that's striking you? And if you don't do many of these, it's going to be difficult. Or if you have done these, many decades ago, this is all we had. Okay, so we're waiting now for the arthrogram, but in the meantime, keep in mind that patients may become claustrophobic. They may refuse to go in the magnet. Sometimes all you get are your fluoroscopic images, so don't forget to take some pictures while you're there. But here is the MR arthrogram. So I'm showing you an axial as well as a sagittal image. So if you look at these two together, there's something definitely abnormal. And what is that? So what is the most likely diagnosis? Is it a torn posterior labrum, prior shoulder dislocation, ruptured biceps tendon, or do you think it's normal? Okay, so those who have their devices, why don't you please vote, see what you think. All right. Okay, great. So most people got this correct. That is true. This is a ruptured biceps tendon. Okay, so we're going to go through the findings here. So if you look carefully, when we do an arthrogram, you can either go high in the rotator interval, you can inject lower near the inferior medial humeral neck. You can also go posteriorly. Some people will be blinded or under ultrasound guidance. So it doesn't matter as long as you're in that joint. But the normal bicipital tendon sheath should end somewhere about this region. And if you look at this, it's completely filled with contrast. And if you look carefully, which may be difficult in the back of the room to see, but there is a retracted filling defect more distally. So what you're dealing with is the fact that you have a proximally ruptured biceps tendon. This is the long head. So this is the most commonly torn by far. It's really unusual at the level of the shoulder to have a torn short head of the biceps. And here you can see a vacant bicipital groove. Okay, next case. So I'm going to show you two sagittal images on an MR arthrogram and need you to tell me what is the diagnosis. Okay, is this extravasated contrast? Is there a displaced subscapularis tendon tear, posterior labral tear, or has there been remote trauma? Okay, so place your votes. What are you thinking? All right, we need some more green here. Okay, so this is a difficult question. Okay, so we have a mixed bag of what people answered, but I think most people are putting displaced subscapularis tendon tear, which is not correct, but let's go through this. Okay, so if we could, we're going to reload the talk. Okay, so this is remote trauma. And the reason why this is remote trauma is because if you look at the shape of the glenoid on a sagittal image, you should have a pear-shaped, just like we're showing you here. It's not a complete sphere. It's not an oval. It's going to be somewhat asymmetric from front to back. So there's something that's going through the expected contour of the anterior and the anterior-inferior glenoid. So what that is, in conjunction with marked flattening of the posterior aspect of the humeral head, are Hill-Sachs and osseous Bankart lesions. So in these cases, they're really well demarcated. There's no bone marrow edema on the other sequences we have, and this is the result of a prior anterior shoulder dislocation. So just to show you some companion cases, here's a patient who is actively dislocated within the MRI scanner. So this is highly uncommon. These are patients who, for whatever reason, they cannot reduce these within orthopedics. They've sedated them, they're having difficulty. They want to know what exactly is the damage before they reduce and likely create an additional fracture in these difficult reductions. So if you look at this, it's very complex. So I'm showing you in axial and coronal images. But if you look at this, the supraspinatus tendon is very stretched as it's dislocated. And you can see that there's partial thickness tearing in addition to the Hill-Sachs and the Bankart lesions. Here's a different patient. So once it's, you look at an axial image, it's very easy to assess these, but the terminology that we use to communicate with the orthopedic surgeons is an engaged Hill-Sachs lesion, which means it's actively impacted upon the anterior inferior glenoid. Okay, here's a different patient. So this is a 43-year-old man, and he presented with shoulder pain. So I'm showing you an image from a chest x-ray and then blowing up the left shoulder for you to appreciate this. So if you look at the left shoulder, does anything strike you? Okay, how about if I give you an axial MR to correlate with that? So right through the glenohumeral joint. So what do you think the diagnosis is? Is it a teres minor avulsion, Hill-Sachs lesion, reverse Bankart, or are we dealing with glenoid hypoplasia? Okay, so place your votes. Okay, great. So about 50-50. It's difficult, but glenoid hypoplasia is the finding. Okay, so we're going to go through this. So on a chest x-ray, this is shot straight anterior to posterior. And if you think about the lie of the glenohumeral joints, they're angled. So think about any chest x-ray, chest CT you're reading. There's an angulation to the glenohumeral joints. They're not straight in face with the x-ray beam. So if you happen to see the glenohumeral joint in profile, you know there's something deficient about the angulation. And so glenoid hypoplasia, this is something that we see either congenitally, or I think really we're dealing with a lot of patients who are doing early bench pressing when they're skeletally immature, and when they do that, they're really putting increased pressure on the posterior aspect of their glenoids. Pitchers can also do this when they do marked external rotation. They put a lot of pressure on the posterior part of their glenoid. So normally, this is about the outline of what you would expect to see, and this should be relatively flush to an angle along the long axis of the scapular blade. So if you extend a line along the scapular angle, notice how posteriorly this is angled. It's not 90 degrees at all. And look where the axis is going through the humeral head. There is posterior displacement of that humeral head because it is unstable. And in addition to that, we've got a problem with the posterior labrum. It's torn, and we also see some paralabral cysts. And here's a different patient where it's even more extreme. You just have a very hypoplastic, non-functioning glenoid, which is going to predispose these patients to labral tears as well as dislocations. And in addition, you see a very multiloculated cystic focus. So in the presence of its location next to the labrum or the joint, it's likely going to be a paralabral cyst, and your job is to look for an adjacent labral tear as the source. Okay, next patient. So here is a coronal T1 weighted image after we've injected the gadolinium for an arthrogram. So if you look at this, I'm just going to show you one view, which is not what happens in our daily practice, but I want you to kind of focus on the usual trouble spots that we have, the usual sources of pathology. So would you call this normal? How about a Bankart lesion? How about a superior labral, anterior and posterior, or a slap tear? Or how about a humeral avulsion of the glenohumeral ligament, which involves the bone, which we call a bagel? Okay, so which one do you think it is? Okay, so most people put bagel, and we're going to go through that because it can be a little bit difficult. And I can tell you the answer is actually a Bankart lesion. So there is no bone that's involved, and I'm going to show you at this point why. So the labrum itself should be in this contour right here. So it should be in this corner of the glenoid, similar to the superior labrum. So if you look where it's gone, it's medialized. It's become displaced, and that's a problem. So if you look at the sagittal image, similar to most other anterior shoulder dislocation repeaters, you're going to see these very large lesions, so a very large Hill-Sachs lesion. So these have the potential to engage, and here you can see there's a little bit of an indentation as well. Okay, so this is a different patient, 17-year-old boy with shoulder pain. So looking through coronal imaging, this is an arthrogram, and we'll show you some axial imaging. What do you think the diagnosis is? Is this a normal variant? Do you think he's ruptured his biceps tendon? Is there a type 3 slap tear? Or is there partial thickness supraspinatus tendon tear? Okay, so place your votes. Perfect. So almost everybody got this correct. That is correct. This is a slap tear. So going through the superior labral tears, this is a representation from Bell-Trans images and Stoller, which are beautiful. But what you're seeing is the displaced bucket handle component of this superior labral tear that's being inferiorly displaced into that superior joint. So this is one of the many types of SLAP tears, and there's up to 10 or more which you don't need to know. You can reference them if you'd like, but in reality, it comes down to about 4 SLAP tears that are reasonable for people who are interfacing with the orthopedic surgeons to know. And the most common is actually a type 2. But type 1, this is simply just fraying and degeneration of that superior labrum. Type 2, there's an avulsion of that superior labrum and biceps anchor, but the biceps attachment's not displaced. And here's what it looks like on a type 1. Just a little bit of superficial fraying, and sometimes this is difficult to assess. And when it comes to older patients, 50 years of age and older, a lot of people are starting to have degenerative, and you're having degenerative tears. They don't necessarily count as a SLAP tear. So if it's an older person, I don't use the word SLAP tears. Usually in the younger athletic patients is where this is an issue. This is a type 2. You can see there's increased signal within the substance, widening of that interval. Here's another example of a type 2 lesion. So look at that increased signal within it as opposed to a normal variant. Just to show the difference, this is a sublabral recess where you see some undermining of the labrum from the glenoid. You can see the intact cartilage. This looks completely normal, very smooth, very narrow. And there's another normal variant called the sublabral foramen. So you can have focal detachment or a hole with the superior anterior labrum. So in that 12 to 3 o'clock position of the labrum, be very cautious in calling pathology because oftentimes this is going to be a normal variant in these patients. So another patient with a type 2 tear, you can see it's irregular, it's widened, going into the substance of the labrum and extending actually towards the patient's superior shoulder in the orientation. Another patient, just to bring it home, increased signal with the contrast. Here it's going from anterior to posterior, and your home base is actually the origin of the long head of the biceps tendon. Okay, and then types 3 and type 4, we'll end on that. Type 3 is a bucket handle tear. So this is the case that we were given, and that's really going to start to involve displacement into the joint. And whether or not it involves the long head of the biceps differentiates the 3s from the 4s. So here's a type 3 in a different patient. Here is a piece of meniscal tissue which has become displaced. If you look at what's left superiorly, it's very abnormal morphology. It's not the typical black triangle that you're expecting. Here you can see as well, moving anterior to posterior. And then here's finally a type 4. So the type 4 is going to actually have a bucket handle tear similar to meniscal tears that we see within the knee. So it's going to propagate along the axis of the long head of the biceps tendon. And if you look on the next imaging towards the joint, it's going to start to propagate, and you can see those two together. So this is a type 4 lesion. All right, so that will conclude the session on shoulder. We thank you for your attention. Okay. So what is next?
Thank you so much, Dr. Bancroft. Our next session is going to be myself, Stacy Smith from Brigham Women's Hospital, and I will be talking about soft tissue lesions. So hopefully you guys are getting a handle on the Diagnosis Live program and enjoying learning about these sessions. Our first case, this is a 58-year-old with right knee pain following motor vehicle accident. Outside MRI images were provided, and I'll let you just look at those and kind of get an idea of what is going on in both the radiograph and the T1 and the fluid-sensitive MR sequences. And let's go to our question. What is the best diagnosis in this patient and the next best step? I'll let you look at that. Is it a complete cruciate tear? Go to surgery. Is it a tibial plateau fracture? Go to surgery. Recent complete tib-fib dislocation? Do imaging to exclude vascular injury. Or is it a lateral collateral ligament injury and do nothing, just conservative management. I see the numbers ticking up there. Okay, let's have a look. So 60% of you saw this correctly. This is a recent complete tibiofibular dislocation, and you need CTA or MRA to exclude vascular injury. So what did we see in this case? Well, we see widening of the medial femoral tibial joint. We see an avulsion fragment in the joint. That tells us there's likely something that has disrupted the ligaments. In this case, there's rupture of the deep MCL. There's complete rupture of the lateral collateral ligament complex. There's ACL and PCL complex tears, and there's a lot of hemorrhage posteriorly. So we need to identify that this has been a four-ligament injury, and we need to be worried about vascular access. And when there's four-ligament injury, this is a sign you have had dislocation. Many patients actually spontaneously reduce after a dislocation, and they may have reduced before they get to your institution or before imaging. When we see injuries to the MCL or LCL, we need to do an MRI to look for the posterior lateral corner injury in elite athletes. What we are worried about, though, mostly in dislocation, is injury to the popliteal vessels and to the perineal nerves. It happened in just under a quarter of patients. So even if that patient is reduced, they need to have some further injury. And we can see this complete popliteal transection in this angio study on that patient that we had just seen. Thinking about what's the most common type of dislocation in the knee. Is it posterior, lateral, anterior, or rotatory? And I will bring that up for you to use your devices and let you start answering. I see we've got more people entering the course, so that's great. Okay, I'll give you a few seconds to input your answers. And it's interesting, this question doesn't go as fast as the shoulder dislocation question. Okay. So majority of you thought it was posterior, and the answer is actually anterior dislocation, and 32% of you got that. Let's go back out. I'll go to my next slide. So there's 5 types. As I said, anterior is probably the most common, about 40%, with posterior following very closely behind. And it's, like I said, there's usually high impact trauma or fall from a height. There's several different classifications. We're not going to go into that in this particular course, but you can look those up on your own. And so look at the clinical and imaging findings to decide whether you are going to do the further imaging. And this is a very frank case of tib-fem dislocation, and here we have angio with some non-occlusive thrombosis of the left posterior tibialis. We'll move on to our next case. This is a 32-year-old male with ankle pain and swelling. And I'm not going to tell you any more about that, but next question is, what space is the abnormality encroaching on? Is it the retrocalcaneal bursa, Kager's fat pad, the joint space, or the sinus tarsi? So let's get your devices loaded up. Go ahead and start answering. Okay. I'm going to move on. And it is very nice. Kager's fat pad, and you guys got that very, very fast. So there's Kager's fat pad. Is normally a triangular area of fat in between the anterior Achilles tendon, which looks fine in this particular case. The retrocalcaneal bursa is here, and that is still fat-filled. The joint space is normal, and the sinus tarsi is normal. But what we're looking at is this soft tissue density within Kager's fat pad. Patient went on to have MR. When you see this in a plain film, you worry about many different things, but you know it's not normal. On our MR, we see several different findings here. There is what looks like muscle signal within the area of the fat pad. It is not bright on the T1 weighted image. It has a little bit of bright, what looks like fat. And on our stir sequence, we can see that there is some edema within this structure. So your next question is, which is false regarding this entity? And I've given you, remember the false. So intact Achilles It may be treated with fasciotomy. It can cause exertional edema, or occurs in 20% of people. Let me give you that to start putting your answers in. Okay, just a few more answers. If we can get past, great, get past 50. So majority said B, can be treated with fasciotomy, which is actually, it can be if it is causing pain. The false entity is that D, and we're going to go into why. It actually occurs in 4 to 10%, so it's not quite a fair question. But what I wanted to emphasize here is that while the Achilles can be involved in these patients and cause edema secondarily, in this patient, the Achilles was actually beautiful. So there's a nice fat line between the Achilles and the Kegers. So it's got to be something different. There's actually still fat in the joint, so it's not coming from the joint per se. And as we can see on these images, it is separate. So this is correct. And these two are both correct. It can cause exertional edema. And so diagnosis in this case is accessory soleus muscle with exertional strain. So the accessory soleus itself occurs in about 4 to 10% of patients. It can be unilateral or bilateral, and it has different anatomic variations. It can arise from the anterior surface of the soleus, or it can come from actually the fibula or soleal line of the tibia, and have a muscle shape and signal as we saw on that MRI. Now, there are certain entities that can be in that differential, such as a hemangioma or an adjacent Achilles injury, a mass, infiltration, or infection, and that's where MRI is very critical. But we can identify this low-lying soleus as its characteristic soft tissue appearance on radiographs, and we can see this very nicely looking just like the soleus, and here's our low-lying soleus on the sagittal MR. On CT or MR, you can see this replacement of the fat with an enlarged structure, and you can see also the large accessory soleus, in this case with no exertional edema. And what happens is this muscle is entrapped during exercise, and over time, if that muscle is too big, you can get swelling and onset during exercise, particularly in adolescent patients with a higher incidence in men. And because the blood supply is tenuous, they can actually get a compartment-like syndrome, and they can be treated with fasciotomy. So it can be a cause of exertional pain in young adults and adolescents. Our case 2. This is a 25-year-old female with painless, rapidly growing elbow nodule. And we've given you some axial T1 and T2 images and also a sagittal fluid-sensitive sequence. And we're just going to go to anatomy question first off. What compartment is the lesion in? So let's go to your answers. Is it sub-Q or fascial? Sub-Q only, intramuscular, or intermuscular? Okay, very nice. So everyone pretty much got this. This is sub-Q fascial. We can see our fascial plane. It's a deep sub-Q area. And move forward. And there's a specific sign that can help us in the diagnosis of this particular entity. It's very well defined. This is one of those click on the image questions. I just want to see how this works because I haven't done this one. So if you can click on the area that is the fascial sign in this particular patient. There we go. Someone's trying it. Excellent. Okay. So we got lots of fascial signs. Excellent. So what we're looking at are these little intricate areas of signal that go along the fascia. So let's move out. And there's the fascial tail. And this is very characteristic of this particular entity. So we'll see this nodular structure and the small bit of lesion extending along the fascia. And there's several entities that can have this particular fascial sign that goes along the aponeurosis. And it's moderately specific and sensitive for the diagnosis of nodular fasciitis in this particular location. And it's relative to fibrous predominant tumors. It can also be seen in desmoid tumors with T2 hypodense bands, myxofibrosarcoma, and leiomyoma. And we can see here on an ultrasound that fascial plane extending with the lesion seen here and this fibrous lesion. So nodular fasciitis is benign proliferating fibroblastic lesion. It's usually painless in young adults in the upper extremities, as we saw in the elbow in this patient. It can also be seen in the trunk, and they're usually fairly small. The issue is that they have a fairly rapid growth phase, so they can be confused with sarcoma if you aren't in the know of what this is. And these are the typical spindle cells that we see under pathology for these cases. You can see them in sub-Q tissue. They can be intramuscular or fascial, and the one that I showed you is quite characteristic. And in about 15%, you can see these associated with trauma. There's three types: the myxoid, cellular, or fibrous. We look for the fibrous tail, or the fascial tail is an identifying feature, and diffuse enhancement, as we saw on our patient. It's usually a self-limited course, and just observe it after needle diagnosis. And if it is causing discomfort, then you can resect. And just to show you some of the other entities that are fibrous-like lesion, this is an extra-abdominal desmoid tumor. Here we see a neurofibroma with the typical fibrous central target sign on the T1 and other images, and we can also see soft tissue sarcoma. So in the presence of an intramuscular lesion, early myositis may be considered in the differential diagnosis. Our last case, this is a 32-year-old male with a slow-growing painless mass in his thigh and shortness of breath. And you are given a coronal T1 fat-sat pre and post images. And you can look at this. There's enhancement throughout. There's more peripheral, but there is some central area of necrosis, but there's a fair amount of enhancement. We also see vascular structures coming in on our pre-contrast. So next, this is our vascular ultrasound. We can identify the area of enhanced vascular flow on Doppler. Our question is, what is the next best step? Remember, this is a young patient, fast-growing, painless mass. It's very vascular. So let's go to our question. I'll let you answer those. So A, palliative care. B, CT thigh. C, chest imaging. And D, embolization. Okay. Wonderful. 3/4 view. Got this answer correct. Chest imaging. So why is that correct? Well, palliative care in this case isn't going to help us. CT thigh isn't going to help us. We've already seen it's vascular, and we've seen the mass and the necrosis. Embolization, perhaps, but the first thing we need to do is a chest radiograph. In these patients, they are known to metastasize very early, and it's part of the path of this particular entity. And we can see here these round cannonball-like mets in this very young patient. And this is alveolar soft part sarcoma. And this is a very scary lesion when they first are seen. You need to be aware of them and do that chest imaging immediately because it changes management in these particular patients. This is a rare malignant slow-growing vascular soft tissue mass of young adults, children, or adolescents, usually in the 2nd to 4th decade. And it's typically painless, and I said metastasis usually presents at the time of presentation. So chest mets are the most common, and we need to identify those. They may be tender to palpation. You can have a bruit or pulsatile sensation. In the adults, it's usually in the lower extremity. The thigh is probably the most common, as we've seen in this case, but they can occur in the upper extremity in the retroperitoneum. And in kids, they can occur in the head and neck. In a child, you could have a differential diagnosis of a mass, could include rhabdomyosarcoma, but you tend to think more about vascular type lesions, hemangioendothelioma or pericytoma or AVM. Synovial or Ewing sarcoma may be in the differential, but that vascular component, the painless mass, and flow voids that are seen are important. So after your chest imaging, the treatment is to embolize and wide radical resection. So our take-home points for the soft tissue component of this course today is when you see foreligament injury in the knee, think dislocation and make sure you get some sort of arterial or vascular assessment to assess for popliteal transection and nerve injury. In particular, if you have a patient who is spontaneously reduced before they get to you, look for that abnormal widening on your radiographs or an avulsion injury to suggest ligamentous injury. Remember that accessory soleus can mimic a mass. Look at the Achilles and see if that is your cause of abnormality. And particularly look in adolescence, if this is an active athlete or individual, think about exertional edema. Look at the fascial tail sign in a soft tissue painless mass in an upper extremity and that classic marked enhancement for nodular fasciitis. And finally, in a young patient with a slow growing mass that's very vascular, think alveolar soft tissue sarcoma and do chest imaging for metastasis before moving forward. So I thank you for your time. And any questions? I'm just going to check. We do take questions from our virtual participants. Okay. So we have no questions from that group. Any questions from the floor before we move to our next speaker? I'd like to introduce Dr. Linda Probin from the University of Toronto. She will be speaking on cases related to ultrasound in MSK.
Okay, thank you very much. So we're now going to be focusing on MSK ultrasound, and we're going to go through a variety of cases. So our first case, this is a 58-year-old male who presents to the emergency room with knee pain, redness, and swelling, and we were asked to rule out a septic joint and to aspirate. So here are two sagittal images. You can see there of the quadriceps, one with power Doppler. And I'm just going to show you a video loop here, just in the sagittal plane, just going through that same region. Okay, so the first question is, what's the next most important step for the diagnosis and management of this patient? Is it to aspirate the joint under ultrasound guidance, obtain an ESR and CRP, ask the patient if there is a history of other joints involved, or send the patient back to ER? Okay. So, most of you thought to ask the patient if there is a history of other joints involved, and that is the correct answer. So, this particular patient describes foot pain, and you notice that the patient has had x-rays, and here they are, of the foot. So, what is the most likely diagnosis now? Is it calcific periarthritis or hydroxyapatite depositional disease, gout, septic arthritis, or CPPD? Quicker responses now, that's good. Okay, so most of you thought this was gout. Excellent, that is what this is. So, gout. So gout is really the oldest recognized arthropathy. It's more common in males, and it's due to hyperuricemia, or increased uric acid in the blood, which leads to the deposition of monosodium urate crystals. These crystals are strongly negatively birefringent on polarized light microscopy. There are two types. The first is primary or idiopathic, which is due to an inborn error of metabolism. And there's a secondary form, and both of these would lead to increased uric acid in the blood. The crystals deposit in tissues with poor blood supply. So here are a few things, just if you want to prevent having gout, and I'm just going to highlight a couple of these things. Hopefully you haven't indulged too much while you've been here in Chicago, and we don't have a gout epidemic. There are some things that are good to eat, and things that can help to reduce uric acid in your blood. These are foods that are low in purines. So caffeine is one, and dark chocolate is another, so please enjoy those. And low-fat yogurt has actually been shown to reduce uric acid in the blood. So those are good things to eat if you want to prevent a gout attack. So gout is most common at the first MTP joint. We see these juxta-articular erosions with sclerotic overhanging edges. They're very characteristic, and these can actually also be at a distance from the joint, so they don't have to be right at the joint margin. The calcium precipitates with the urate crystals, causing these varying densities called tophi, and they can erode the bone. But the bone changes are permanent, even though with treatment those tophi can go away, so you don't always have to see the tophi. Here's just another case we had. This was a soft tissue lump in the patient's foot, so we were asked to scan through that. You can see all this shadowing that's occurring just below this echogenic material here. The patient did not have x-rays at the time, but we were suspicious, so we sent her for x-rays, and in fact, this is what we were ultrasounding here, this large tophus at her first MTP. So that's where you want to ask for plain film correlation. So these tophi deposit in the synovium, articular cartilage, and then the subchondral bone, and they could occur in other sites, not just that first MTP. And here's one in the knee, characteristic erosion, but not a common location. And here are tophi in the spine, also causing those erosions, and you can see the dense soft tissue. So that's the giveaway. You can use dual energy CT if you have that available to you to help with the diagnosis, although it's not always necessary. And that uses two energies of CT, of KVs, and post-processing is performed to differentiate the attenuation values. And in this particular case, the green is the gout deposits just in the patellar tendon. So as I mentioned, tophi can deposit in other locations. They can deposit in the capsules and in the periarticular soft tissues, ligaments, and tendons. And that's what's happened in this case at the knee. So here we have the quadriceps tendon. There's a small amount of fluid, but not a big joint effusion. And the abnormality here is this soft tissue on top of the quadriceps tendon, which was very vascular on power Doppler. So we were asked to aspirate the joint, but we didn't do that. What we did was we stuck a needle into this hypoechoic region, which this is what we got. This was very thick, creamy, milky. We could make the diagnosis pretty much right away. So the treatment for gout is medications, so anything to reduce the production of uric acid or anti-inflammatories. And there's many different diets. If you look this up, you can see different diets. Basically, they're all low in uric acid, and there's many home remedies that they recommend. Okay, moving on to our next case. So this is a 49-year-old male who complains of a lump at the medial aspect of the left ankle. And you can see here's a static transverse ultrasound image at the medial ankle. And here it is in longitudinal. You'll see there's Doppler on there as well. And I'm just going to show you a video loop through this region in the transverse orientation, just coming through the medial aspect of the ankle. Okay, so the question here is, the patient also likely has paresthesias in the sole of the foot, paresthesias in the first web space, a drop foot, or a positive Thompson test. Okay. So most of you thought B, which is paresthesias in the first web space, and close behind that is paresthesias in the sole of the foot. So the correct answer is paresthesias in the sole of the foot, and I'm going to explain to you in just a moment, but I have one more question first. The most likely diagnosis is superficial peroneal nerve compression, tibialis anterior tendon tear, deep peroneal nerve compression, or tarsal tunnel syndrome. Okay, so most of you thought tarsal tunnel syndrome, and that's what this is. So tarsal tunnel syndrome is an entrapment neuropathy of the posterior tibial nerve, and it's usually unilateral. When patients present with paresthesias in the toes and the sole or the heel, and a positive Tinel sign, not a Thompson test, a Tinel sign, where tapping at the medial aspect of the ankle just below the medial malleolus at the region of the nerve causes the patient's symptoms. So the tarsal tunnel is bordered by a roof, which is the flexor retinaculum. The medial wall is the talus, and the floor is the calcaneus. Just distal to the medial malleolus, the tibial nerve enters the tarsal tunnel posterior to the posterior tibial artery. So that's the location of it. So there's many causes of tarsal tunnel syndrome. The most common would be ganglion cysts, and other things would be fractures and tenosynovitis. The posterior tibial nerve sends branches to the heel, so that's why patients can have heel pain. They also have medial and lateral branches as well, and this supplies the sole of the foot, the toes, and the intrinsic muscles of the foot. So patients will have pain in their heel, the plantar aspect of the foot and toes, and weak toe flexion. Okay, next case. This is a 63-year-old male who complains of pain and swelling at the dorsal aspect of the wrist. So I have for you here a transverse image here at the dorsal wrist. You can see the color Doppler is on. And I also have here a video loop. So just watch this loop go through here, the same area in the transverse orientation. I'll let you watch it twice. Okay, so the most likely diagnosis is tear of the extensor pollicis longus tendon, proximal intersection syndrome, distal intersection syndrome, or de Quervain's tenosynovitis. Okay, and the majority thought that this is distal intersection syndrome, which this is. Just going to go through this here. So just to review the anatomy here, this is really important. So just the first three extensor tendons is what we're going to focus on here. And you can see here, I'm just going to highlight compartment 2, extensor carpi radialis longus and brevis. And here's compartment 1, abductor pollicis longus and brevis, which both go to the thumb. And those tendons cross over compartment 2 here proximally in the distal forearm, and that's where there's a proximal intersection. More distally, just after Lister's tubercle, which is this bony bump here, extensor pollicis longus crosses over compartment 2. So this is the site of the distal intersection. And here's just an MR image, and I'm just going to go in this way from proximal to distal. Just focus here on Lister's tubercle and extensor pollicis longus tendon. Just keep your eye on that as this video loop goes through. Just keep your eye. See how the tendon crosses over compartment 2 to get to the thumb. Here's the same thing in ultrasound. You can see here, there's just Lister's tubercle here, and keep your eye on extensor pollicis longus, and just watch the tendon as it crosses over top of compartment 2 to get to the thumb. So the proximal intersection syndrome is a an overuse tenosynovitis occurring again right in this location, and it occurs where compartment 1 crosses over compartment 2. This is common in weightlifters, rowers, and racket sport players. Here's what it looks like on MRI. You can see here all this edema where the tendons are crossing up here again. This is in the distal forearm. And here on ultrasound, we can see the same thing. We often just see a little bit of fluid between these tendons as they cross. Distal intersection syndrome, which is the case I showed you, is a tenosynovitis again as the third tendon, extensor pollicis longus, crosses over compartment 2. So this occurs just distal to Lister's tubercle, and the tendon sheaths are actually connected by a foramen. So typically both tendons will have fluid around them, and here's just an axial MR image showing fluid around these tendons as they're crossing. And here's again the ultrasound that I showed you. There's extensor pollicis longus. Keep your eye on that. It's going to, just after Lister's tubercle, it's going to cross over, and you can see the fluid around these two tendon sheaths. Okay, we're going to move on to our fourth case. So this is a 78-year-old female who complains of pain and locking. And what I have here for you, the images on the left of the screen are longitudinal at the level of the volar third MCP. So this is the flexor tendons of the fingers. So here's the at the level of the MCP, and here in the bottom image is with power Doppler. And turn transverse in the same region. Here, this is a short axis ultrasound image of the same tendon at the level of the third MCP. I have a video loop to show you as well. Okay, So the most likely diagnosis is tenosynovitis, Dupuytren's contracture, trigger finger, or a pulley injury. Okay, most of you thought this is trigger finger, which this is. So trigger finger. So there are 5 pulleys of the finger. A1, A3, and A5 are located at the MCP, PIP, and DIP joints respectively. And these pulleys originate from the palmar plate at those joints. The A1 pulley, which is this one right here at the MCP joint, that's the one that's typically involved with the trigger finger. And just so you know, also there are 3 cruciate pulleys, and these are cruciate for the name because they crisscross, and they prevent the tendon sheath from collapsing and expanding during finger motion. So these pulleys really help to keep the tendons adjacent to the bones as we flex and extend our fingers for functional purposes. I'm just going to show you here, this is the A2 pulley. You can see this is a bit of a broader, longer pulley here, and it's located along the proximal phalanx. And this is what it looks like on ultrasound. So you can see that these are very thin in the normal case, less than 1 millimeter in thickness. So if you don't look for them, you often won't even notice them when you ultrasound this region. In trigger fingers, I mentioned it's mostly at the A1 pulley, which is at the level of the MCP. And on ultrasound, what we can see often is thickening of the pulley. So you can see up here, these pulleys become thick, so now you can actually see them quite nicely, and they can get inflamed as well. You can have associated small little cysts around this region, and the tendon may or may not be thickened and edematous, so you may have some tendinopathy there as well, which exacerbates the clicking phenomenon. So here is that longitudinal image through this region. I showed you this video loop already. I'm just going to show you again. It's a little slow. These are hard to capture on ultrasound. You can see here the tendon is bunching up underneath this thickened pulley, and then it suddenly releases. And you can often hear this and watch it as you're ultrasounding that region. But again, it can be definitely difficult to capture on ultrasound. It's a very quick snap. There it goes and it releases. So the A2 and the A4 pulleys are the most important for function. As I showed you on that previous image, the A2 pulley is a broader pulley than the other ones. And in rock climbers, the A2 pulley is the most likely to be injured. So there's the A2 pulley and there's the A4 pulley. And when there's injury here, what happens is the tendon now bowstrings. So it's now elevated from the underlying bone. You can see people with rock climbing, when they have hyperextension of the DIP and hyperflexion of the PIP, is typically how the tearing occurs. Here's an extended field of view. You can see here the MCP, PIP, and DIP joints, and just taking an axial image or a short axis image through this region here in the normal case, you can see again that very thin, imperceptible pulley, and the tendon is adjacent to the bone. Here's a rock climber who has an A2 pulley injury. I'm just going to magnify this area up here that's outlined in the yellow rectangle. And you can see this, what's happened here now with the pulley tear is the tendon is now elevated from the underlying bone. So it's now bowstringing. And just an axial image right through that area, you can see here now the tendon is elevated from the underlying bone, and you don't see the pulley attaching anymore to the bone. Okay, we're going to move on to the 5th case, which is our last case. This is a 24-year-old male who complains of pain and swelling at the base of the thumb. So these are both longitudinal images at the ulnar aspect of the first MCP joint. And I'm just going to show you here as well a video loop. Okay, so the most likely diagnosis is a Stenner's lesion, tear of the ulnar collateral ligament with an intact aponeurosis, tear of the ulnar collateral ligament and the aponeurosis, so both being torn, or an intact ulnar collateral ligament and a tear of the aponeurosis. Okay, so most of you thought this was B, tear of the ulnar collateral ligament with an intact aponeurosis, which is the correct answer. So, just going to review the normal anatomy of the ulnar collateral ligament, which is really important to understanding the pathology in this region. So the ulnar collateral ligament spans from the MCP to the proximal phalangeal base in this orientation. On top of it is the adductor aponeurosis. So that as a superficial structure to the ulnar collateral ligament. And that aponeurosis attaches to the extensor pollicis longus tendon. So that becomes important when I show you how to make the diagnosis of a Stenner's lesion on ultrasound. So just keep that anatomy in mind. When we ultrasound the ulnar collateral ligament, this is the best way to position the patient's hand. It's just sort of bunching up the towel and having the thumb hanging over the edge of the towel. You'll see, I'm just going to show you in a minute a maneuver, but you really want to put your probe, and if you have a hockey stick or a small footprint probe, that is the most ideal, but you really put in orienting it coronally on the thumb. So you can get right in there. If you have the patient's hand flat on a towel or just on the table, you won't be able to see the structure well. So what the normal ligament looks like is right here. I'm just tracing it there by the arrow. Again, it spans the metacarpal to the proximal phalanx. And the adductor aponeurosis is a very thin, almost imperceptible, usually hypoechoic, or it should be hypoechoic structure, just right on top. In the normal situation, it's sometimes hard to see. But there are some maneuvers that we can do. So the first thing we can do is flex and extend the thumb, and that's why it's so important to have the patient's thumb over the edge of the towel there. Remember, the aponeurosis attaches to the extensor pollicis longus. So when we do that, we can actually see the black structure there, the aponeurosis, gliding over top of the ligament. So that really, if you see that, then it is intact, no question. The other thing we can do with the patients in that location or in that position is stress the thumb by putting pressure towards the table. And by doing that, you'll see here that we can stress the ligament here. So it's really nice to see that the ligament is intact. So just to show you on MRI, we can see the ulnar collateral ligament nicely here, and the adductor aponeurosis is right on top of it as a thin band. Skier's thumb is typically an abduction, an extension, or a valgus force on the ulnar collateral ligament, and this typical situation is landing on top of a ski pole like that. There's a spectrum of injuries. You can avulse a piece of bone from the base of the proximal phalanx, or you can have an isolated ligament injury. And there's different degrees of injury, from a sprain to a displaced fragment of the ulnar collateral ligament that goes on top of the aponeurosis. So that's a Stenner's lesion. So here on MRI is just a tear of the ligament, but it's not actually displaced. There's the aponeurosis on top of it. And here's one that is torn. You can see here that the ulnar collateral ligament is actually lying horizontal, and there is the aponeurosis. So that would be a Stenner's lesion. They typically call this the yo-yo on a string appearance, as the aponeurosis and the displaced ligament look like that. Here's just the spectrum of pathology. So here's a small echogenic region just at the base of the proximal phalanx. The aponeurosis is intact. So this is just a small avulsion, but an intact aponeurosis. Here's a larger partial tear with the aponeurosis intact. And this one here would be a Stenner's lesion. So the ulnar collateral ligament is completely displaced. The aponeurosis takes a deep dive, and that is a Stenner's lesion. So the treatment is typically conservative for partial tears or non-displaced fractures, but surgical treatment is required for the Stenner's lesions or the larger displaced osseous fragments. Just a quick note on prevention, just summing it up here. So when you go to ski to prevent this injury from happening, most people will put their hand through the ski strap like that. And then what happens when you let go, you fall directly on the ski pole. So that's what you don't want to do. That's how you're going to get a Stenner's lesion. The correct way to hold a ski pole is to bring your hand below the strap, like that. Put your hand down onto the handle. So when you let go, the pole moves away from your hand, and you will now not land on the pole. So you won't get a Stenner's lesion, but you might get a scaphoid fracture. So you can pick the lesser of two evils. Okay, so thank you very much for your attention.
Thank you. Excellent presentation. I've learned how to ski differently now. I would like to next introduce our next speaker. I'm delighted to introduce Dr. Glenn Gaviola. He is a musculoskeletal radiologist at Brigham and Women's Hospital, Harvard Medical School, where he is also the residency program director, and he will be speaking on spine lesions. Dr. Gaviola.
Thank you, Dr. Smith. Good morning, everybody. So today we're going to be talking about spine lesions and in particular looking at radiologic signs. And I know I spent a majority of my training really trying to figure out which things are worrisome and which things are not for when we look at malignancy. And so we're going to focus the theme a little bit on these, on this particular question on when should we worry or not when we see these radiologic signs. So we're going to review some commonly encountered radiologic signs in spine imaging today, and then kind of take a look and see what are the pathologic basis responsible for their imaging appearance. And then ultimately what we want to do is determine which imaging findings are worrisome for malignancy. So we're also going to be using the devices today. So here's our first question. This is where is the abnormality? So where is the abnormal finding on this patient's lumbar spine radiograph? So just mark the correct spot here. All right, excellent. So we've got about half of the audience here. So let's see what we've got. Excellent. So we have a significant number that are in the right spot here. So here's the abnormality. So you can see if we look at this L3 vertebral body, we can see that there's a cortical destruction and irregularity, the inferior end plate, as well as absence of the right pedicle here when compared to the left and with the adjacent levels. So the finding is best seen on CT, where you can see that there's a destructive lytic lesion, again with the cortical destruction and the trabecular disruption as well. And on axial images, you can actually see that there's a large soft tissue component that's related to this. And there's destruction of the anterior, middle, and extending into the pedicle of that vertebral body. And many of you will recall that this is the absent pedicle sign. So the absent pedicle sign or the winking owl sign, this is where there's pedicular involvement in radiography of the spine. And this was originally described using radiographs, where there's the destruction of the pedicle is seen as the most common finding for metastatic disease in about 30% of the cases. It's important to note that the pedicle is not necessarily the primary site of metastatic involvement, but it's usually the first area that's identified on radiographs. So it's in combination with involvement of that posterior body, and oftentimes on the CT scan you'll see the extent of the lesion itself. All of this is related to the fact that the tumor deposition that occurs there correlates to the site of the vertebral vessel entry into that area. And of course, as we all know, this is one of the most worrisome signs that you want to look at on radiographs to identify what the underlying lesion is. So in this particular case, this patient had a history of Ewing sarcoma previously, and after biopsy of this lesion, this was determined to be metastatic Ewing sarcoma, which is not very common to see in the spine, but it certainly is with regards to the findings here. So Ewing sarcoma is a highly aggressive tumor with a large soft tissue component that tends to invade the local tissues. Within the spine, you'll mostly see it involving the sacrum and in the lower axis in the lumbar spine. And it has the propensity to involve the posterior elements with bone destruction, and it can lead to collapse and fracture. Histologically, these are round blue cell tumors with a similarity to neuroectodermal origins. And the clinical findings can often be very challenging with these, but they're usually younger patients within the first 3 decades of life, more men than females, and they can oftentimes present with very confusing symptoms of pain, fever, anemia, weight loss, and leukocytosis, almost mimicking that of an infection. So ultimately, biopsy may be necessary for these particular lesions to differentiate it from a neoplastic or an infectious process. All right, so we're going to move on to case 2 here. So here's our next case. So regarding the diffusely abnormal appearance of the L1 vertebral body here, which is labeled, which of the following is the least likely etiology? So you can use your devices to help answer this question. So again, diffusely abnormal appearance of L1, least likely etiology. Is it a vertebral hemangioma? That's less likely. Paget's disease, prostate cancer metastasis, or lymphoma? See if we can get about half the audience here participating. right. Let's see what the poll says. So in this particular case, about a third of the group identified the correct answer, which is Paget's disease, and vertebral hemangioma was the more common answer. So let's figure out why that's the situation in this particular case. So Paget's disease, so this is also known as the ivory vertebra. So you can see that there's diffuse increased density of the L1 vertebral body when compared to the other vertebral bodies, also known as the ivory vertebra sign. And again, this was described using conventional radiography, presenting with the diffuse and homogeneous increase in the density of a vertebral body. What's really important about the finding is that the vertebral body has a preserved size and contours, and that the adjacent discs also have the preserved density and size as you would expect from the adjacent discs. So your top differentials when you see this are going to be metastases, in particular osteoblastic sclerotic mets, usually prostate and breast metastases. Lymphomas infiltration is also another area that you want to think about. And why do these look increase in density? Well, that's because there's an osteoblastic response to the underlying tumor infiltrating the spongiosum of the bone, as well as increasing bone formation as a result of that process. So of course, when you see a vertebral body, that's increased in density, you want to worry whether this could be metastatic disease or lymphoma, particularly if the patient has a known diagnosis of both. Here's an example of a more common feature of the ivory vertebral body. You can see that there's increased density in the L4 here when compared to the others. A more typical example. So you'd go through the same differential diagnosis, and on cross-sectional imaging, this patient actually showed that there was actually multifocal disease. So even though on radiography the sensitivity was only for that of that L4 vertebral body, cross-sectional imaging is helpful to identify multifocal disease, and this patient had a history of breast cancer metastases. So the answer here was Paget's disease in terms of what's least likely. So it is in our differential for an ivory vertebral body. So Paget's disease, also known as osteitis deformans, it has a coarse intratrabecular pattern, and usually that's what's increasing the density of it. But what's different about it compared to the other disease entities in the differential is that there's usually an associated increase in the size of the vertebral body. And in terms of the increase in density, it usually predominates along the cortex. So most often, before you get the ivory vertebra, you'll see a picture-framed appearance of the vertebral body. Again, the reason we see this is because there's increased osteoclastic bony resorption, followed by atrophy of the spongiosum, and then disorganized osteoblastic bone repair, which is why it increases the density that we have. All right. So the patient had additional cross-sectional imaging to try to narrow down the differential, and here's what the cross-sectional CT imaging demonstrated. So we're going to move on to our next question. So regarding the diffuse abnormal appearance of L1 vertebral body, which is now the most likely etiology. And you'll see the question's very similar except for the most likely part now. So again, same answer choices: vertebral hemangioma, Paget's disease, prostate cancer metastasis, or lymphoma. So with those of you with test-taking skills, you know you have a 75% chance of getting this right. Great. Excellent. Perfect. So we got the majority here wins, so vertebral hemangioma. So excellent. So that is the correct answer in this particular case. So this is an example of vertebral hemangioma presenting as an ivory vertebra. You'll notice that on the CT, it gives us much better bony detailed evaluation of the underlying bone. And you see this coarse honeycomb appearance to the vertebral body. And then on the axial images, you can see all these dots, these white dots that are peppered throughout the entire vertebral body, all the way into the pedicles and posterior elements. And this is a nice example of diffuse involvement of a vertebral body from a vertebral hemangioma. So this is in the differential, and you want to think about this in the ivory vertebral body differential. So this is the most common benign spinal tumor, if you will, when you see in the vertebral body, when in fact it actually is a hamartoma of multiple different elements in there, endothelial cells. These are usually asymptomatic, incidental findings with about a 10% finding at autopsy. It's important to note that vertebral hemangiomas can present as either focal lesions or diffuse involvement of the vertebral body. So on radiography, you'll see these exaggerated vertical striations and that honeycomb pattern that's contributing to that. Pathologically, what's happening is we have thin wall endothelial cells that are between these thickened vertical trabeculae in the medullary space interspersed with fat stroma, which is what contributes to a lot of the low density and then the high signal on MRIs with these. So again, these vertical striations, and then on axial images, you get those polka dot appearance. So this is also known as the polka dot sign. So this is diagnostic of a benign vertebral hemangioma. Again, this is from the axial images that we see from these thickened trabeculae in the medullary cavity. And again, this is due to reinforcement of an osseous network adjacent to these vascular channels and endothelial cells that's causing the bony focal resorption there. So just the companion case here, this was an example of a diffuse hemangioma. Here on the left, you see that there is focal involvement in the L4 vertebral body. This has a geographic lucent lesion with a sclerotic margin. And again, you'll see these coarse and polka dots throughout the body itself. So it can either involve the entire body or just focally like this. And more commonly, this is how many of us probably see many of these hemangiomas. Again, when you see the polka dot sign, this is the do not worry type of lesion when we see these. All right. On to our next case. So this came to us as a outside hospital consultation. This was a gentleman who is a 91-year-old male who was complaining of low back pain and had a remote history of prostate cancer several years ago. And the concern was a focal low signal lesion within the vertebral body that was identified here. And the outside oncologist wanted us to know if we needed to biopsy this. So the question is this finding worrisome for metastatic disease? So you guys can flip a coin if get the best chances here. So these are T1, T2, and our fluid-sensitive sequences. All right, so true is the majority. I'm actually saying false, B. All right, so let's go through the answer here and figure out what we're dealing with. So basically, we have heterogeneous marrow signal, and what was identified was this focal low signal intensity lesion on the T1 and the T2 weighted images. And you'll notice that centrally within that, there's a central focus of what looks like fat signal. It's bright on T1 and T2, and it's dark on STIR. And you'll notice the whole lesion is dark on the STIR images. So as regarding the answer, this is false, as the majority identified. So this is also known as the bullseye sign, and it's a nice sign that demonstrates basically hematopoietic marrow in the spine. So furthermore, the oncologist was still concerned that this is how the study was originally read despite our consultation, had a bone scan that was ultimately negative for metastatic disease, and a PSA that was normal. So the bullseye sign is a characteristic sign and finding of benign hematopoietic marrow. This was originally described as a focus of high T1 signal intensity in the center of an osseous marrow lesion with a pretty high degree of sensitivity and specificity in the original study. So recognize that when we have marrow development, histologically, the yellow marrow begins centrally, while the reconversion of hematopoietic marrow begins peripherally. And that's the reason why you get that bright signal in the middle of these lesions. And again, this was originally described using pelvic lesions, but you'll notice that you can actually see this in many different areas in the spine. So this is an important sign not to worry when you see this, when you see that central focus of fat signal and bullseye and center within a lesion. This is a do not worry type of lesion. All right, next case here, courtesy of one of my colleagues. This is another spine lesion MRI. So this is a 43-year-old male with a history of non-small cell lung cancer, stage 3A at the time of diagnosis. And again, we get a lot of outside referrals to our cancer program. So here's an example where we have our T1 and T2 images along with the STIR on an MRI, and this is our pre and post contrast T1 images. And I like to keep things simple, again, a lot of questions. So again, this finding is worrisome for metastatic disease. True or false? Let's see what you all think. Great, so about 2/3 said false, and 1/3 said true. So let's figure out what the answer is. So if we look at these images, we'll see that on our T1 weighted images, we have a focal low signal intensity lesion. And on the T2 weighted images and the STIR fluid sensitive sequences, we see a nice rim of high signal intensity. And then after contrast, there you can see that there's actually associated enhancement of that rim of signal intensity after administration of contrast. What's really important to recognize here, if we actually look at the adjacent intervertebral disc, the disc signal is actually preserved and normal. And if we look at the subchondral plate underlying it, it actually preserves that low signal rim line underneath it. So originally you would want to think about, well, could this represent underlying disc disease or even infectious? But generally we'll see abnormalities on both ends of the end plate here with disruption of that end plate. So this is actually true. This is worrisome for metastatic disease. And why is that so? Well, this has been described as the halo sign. And this is indicative of underlying malignancy and seen with that. So this was originally described as a rim of high T2 signal intensity around an osseous marrow lesion, which is indicative of underlying malignancy. Its sensitivity is around 75%, but a specificity of 99.5%. And the idea here that there's secondary to destruction, this is secondary to destruction of the underlying trabeculae with surrounding fluid-filled gap of mucinous or cellular tissue that's underlying the lesion. And this is most commonly seen with prostate metastases due to the low signal intensity and the osteoblastic response associated with these lesions. And again, this was originally described using pelvic lesions. So this is actually a worrisome sign. When you see a halo rim around an underlying marrow lesion, you should worry about an underlying malignancy. So this was ultimately biopsied given the concern that we raised. And you'll see on the CT scan that there actually is associated sclerotic lesion, which is contributing to the low signal intensity of the lesion throughout. And the biopsy confirmed that this was metastatic disease, and unfortunately for the patient, this upgraded them to a stage 4 diagnosis at that time. So again, a worrisome lesion when you see the halo sign. All right, our last case here. So this is a gentleman with a history of prostate cancer with scapular back pain that was radiating to the abdomen. So we had an MR image here. So we have our sagittal and axial T1 and T2s and our fluid-sensitive STIR sequence. So the finding here is that of a compression fracture of the T8 vertebral body. What's important to note on the imaging is that there's no posterior cortical bulging or an associated epidural mass associated with it. So, however, there is diffuse marrow replacement of T8 on our T1 weighted sequences here. You can see that there's diffuse low signal intensity associated with that. So the patient went on to have a CT because there was a concern, well, is this related to the patient's underlying prostate cancer? So the CT scan was done to kind of further evaluate if this is related to an underlying pathologic lesion. And here's what the CT demonstrated. So the question now for you is this finding typical for metastatic prostate cancer? So have your devices out again. So the finding here is this compression fracture with this associated lesion identified on the CT scan. True or false? This finding is typical for metastatic prostate cancer. All right, excellent. So the majority got it here. So false is the correct answer in this particular case. So many of you know that prostate cancer is typically sclerotic or osteoblastic in terms of its findings. And in this particular case, this is a predominantly lytic lesion, osteolytic lesion. What's important to note is that the lytic lesion has these kind of lobulated contours adjacent to it that's depressing the cortex, almost looking like a mini brain appearance with this expansion associated with it. So this is also known as the mini brain sign. So the mini brain sign was described not too long ago as being that pathognomonic for a plasmacytoma. So it's a lytic lesion with a mini brain appearance, and the reason we see this is there's thickened cortical struts that are compensatory to the stress phenomenon from the underlying lytic process that's specific to plasmacytomas. And it's probably less aggressive in nature than other tumors given the fact that it doesn't really expand the cortex much more. And this was originally described using MRI findings in these. And this is a worrisome finding. So when you see this, you would want to worry about an underlying plasmacytoma. And again, you see these cortical struts that are lobulated associated with that lesion. So this was concerning for plasmacytoma. The patient had an underlying skeletal survey that actually was unrevealing, and so they had an isolated lesion. Given the fact that they were symptomatic at the time, this patient was referred for both a biopsy and a therapeutic kyphoplasty, which we performed. And the biopsy did reveal that this was a plasmacytoma. So solitary plasmacytomas are rare. About 3 to 7% of patients with plasma cell neoplasms in the presentation, and roughly 25 to 60% will present in the spine. So this is defined as a single lytic lesion without any plasma cells on the bone marrow examination that's done. It is associated with multiple myeloma, but it's thought to predate that before they have systemic symptoms. And again, what we see on imaging is a lytic lesion with a mini brain appearance that's pathognomonic. Local control with radiotherapy is intended to cure the patient, but if they're age greater than 60, it unfortunately is associated with progression to multiple myeloma. So just to summarize our take-home points, so when do we worry and when do we not worry about underlying lesions? So when you have the polka dot sign, that's characteristic of a benign hemangioma, and the bullseye sign for hematopoietic marrow, these are do not touch and do not worry lesions. When we need to worry is when we are missing the pedicle or an absent pedicle sign. This is worrisome for underlying metastatic disease. The vertebral body, it is worrisome because the first thing you need to do is rule out underlying metastatic disease or lymphoma, and you can see Paget's with it with the expansion of the vertebral body. The halo sign is a rim of T2 signal surrounding sclerotic metastases, is worrisome, and also the mini brain sign is pretty pathognomonic for an underlying plasmacytoma. So thank you for your time, and hopefully we had a chance to review some radiologic spines and spine imaging, and identify the underlying pathologic processes for why we see what we see, and understand which are worrisome for malignancy or not. So thank you very much.